Right, good morning everyone. Kerry, are you there? Can you hear us?
I am. Can you hear me?
I can hear you. Start your video so we can see you.
I've just clicked start. Oh, there I am.
There we go. Hello, good morning everyone. Okay, so I'm Sam Hills, I'm the Clinical Director at Lynton, and this is Kerry Belba here, and today we're going to talk about rosacea mainly, but we'll also touch on some other vascular lesions that we can treat with lasers and IPL systems. So just by way of introduction, then I met Kerry for the first time nearly 14 years ago, I think,
Yeah.
at St Thomas's Hospital, when we were watching, in fact, some people doing vascular treatments, weren't we?
Yeah, they just bought Illumina, I think, haven't they?
That's right, yeah. They've just bought a Lumina AQS system there at St Thomas's. And I can remember particularly the dermatologists there being really impressed with the fact that they were getting such great results on red veins and rosacea, and without the bruising, of course, that you get with the pulsed eye laser. So anyway, today I thought we'd do a sort of a bit of a recap on this. I know you have a special interest, don't you, Kerry, in treating rosacea and red veins and pigmentation with your, I guess, mostly with the 585 handpiece on your Lumina.
Yeah, that's right. So so I've been treating rosacea for about 15 years, and I did a course specifically on the condition, so not laser related, but just to kind of gain a better understanding of the actual condition. And I've absolutely loved treating it, basically because of how it helps people, because people who have it can be really debilitating for a lot of people, and it affects their every single day life. It's the first thing they think about when they wake up in the morning.
Absolutely, because it's not just a cosmetic. It's not, for a lot of people, it's not just the way it looks, is it? It can be really uncomfortable. It can
really uncomfortable.
Yeah. Okay, all right then. Well, anyway, we'll talk through some of that, and if you can give us some tips on on how you do these treatments, I'm sure lots of people here will find that really valuable.
Yeah, I'd love to.
If anyone's got any questions, at the bottom of your screen there's a little Q&A button, so feel free to ask us any questions as we go along. I should point out that neither Kerry or myself are dermatologists, so with any laser treatment or IPL treatment on red veins or pigmentation or anything like that, if you're not 100% sure about what you're treating, you shouldn't be treating it. So, you do need to make sure that you stay well within your comfort zone. But okay, all right, so just to start off then, okay, just to start off then, you may have seen, if anyone watched the laser webinar a couple of weeks ago, you can get all of these on YouTube as well if you want to rewatch them back at any point. You'll have seen a plot similar to this, and what this is basically showing us is the dotted line here is melanin absorption, but the full line here is hemoglobin. So basically where we have peaks are where we can target hemoglobin. Now this one here, this huge peak here, around about 400 nanometers, is blue light, and blue light's very highly scattered by collagen, so it doesn't really treat vessels particularly well, and it just causes a lot of unwanted heating in the topmost layers of the skin in the epidermis. So we don't tend to use blue light, but we can use things like a KTP laser, which is green light, pulsed dye laser at 585 or 595 nanometers, that's yellow light. They can be very useful lasers for treating superficial vascular lesions, and most of the stuff that we see on the face, rosacea, facial telangiectasia, that tends to be very superficial. If you want to treat deeper lesions, then the diode and the ND-YAG are really useful for those. Now, I guess my sort of light device of choice for rosacea would be an IPL. So unlike a laser, IPLs are not monochromatic, so they have a wide range of bandwidth. But with the Lynton IPL system, so with the Luminet, the Lumina, the Exolite, the 3Juve, the 585 handpiece can target this little peak down here, and we can get some really nice results on vessels and rosacea. So again, just to recap, these are the lasers that we would use for vascular lesions. ND-YAG's not going to be ideal for rosacea, because, or even the diode really, because they're just too deep, and the vessels that we're trying to treat are very tiny and on the surface of the skin. So you can use pulsed dyes, you can use KTP, but you tend to then be stuck with you're using smallish little dots, and actually with an IPL, the nice sort of rectangle, large areas can come in really useful for the treatment of rosacea. So rosacea itself, there's not really a test. It's not like you can have a blood test that will tell you that you have rosacea. So it's diagnosed when you are displaying persistent redness in the central portion of your face. So it tends to, you know, affect these areas highlighted here. So the forehead, the cheeks, especially nose, the chin, the sort of sebaceous areas really. And there'll be supporting symptoms as well. So lots of people who have rosacea will say that they flush really easily or they blush really easily. Sometimes they'll have these little papules and pustules on the cheeks. Almost always there'll be some telangiectasia, especially on the curved convex areas. So on the cheeks, on the chin, around the nose, some little thread veins there. Other characteristics then, it can feel really uncomfortable, very tight. It can sort of cause a burning, stinging sensation. It can be very dry. It can get very coarse, and it can even get quite overgrown. So as you can see, this nose here is developing in something called rhinophyma, which is related to rosacea. Lots of people sometimes say it's, you know, alcohol related. It's not, you know, it's related to this condition, rosacea. It can be quite embarrassing for people who have this. You know, people think that they're, you know, drinkers or whatever. No one really knows what causes it, but it does go through distinct stages. So Kerry, do you want to tell us a bit more about those different stages of rosacea?
Yeah, so so basically the one thing I would say is that it is very hereditary. That's one of the first questions I tend to ask people who come in is, you know, do either of your parents have it, or even as far back as sort of grandparents, that it might have skipped their parents, but their grandparents might have it. And what tends to happen, not always, but it tends to manifest itself in your early 20s, and people kind of start to notice that, you know, they seem to flush quite easily, and then it goes, and then suddenly they're flushed and it stays for a few days, and then, you know, and then they're permanently red, and sometimes when it advances, they can get the pustules as well, which I always say, obviously, people never to pick spots, but if one was to pick one of the pustules, it tends to run clear, so it's not like an acne spot. It's not to say that people who have rosacea can't get acne as well, but it is obviously completely different to acne. So it tends to, because by definition it is a progressive inflammatory vascular disorder, it does basically get worse, and for some people it can take years to get worse, and for some people it can be quite a quick process once the initial onset has taken place. So yes, it can be very different for different people, and when people come into your clinic, it can present quite differently as well. You know, some people can have the so the pustules without a lot of general redness. Some people are extremely red. Some people are only a little bit red. It also tends to be in lighter skin types, your skin types 1 and 2 and 3.
Those
but
Celtic skin types, the Irish, Scottish skin types.
Yeah, exactly. So so it tends to be sort of Northern European, but yeah, very, very hereditary. So that's the one thing I always ask, is to see if, you know.
Have you ever seen it in darker skin types? Because I have on occasion. So in skin type 4 and 5, Asian skin types.
Yeah,
and it's incredibly difficult to treat them.
Yeah, I mean, being in Bournemouth, in Bournemouth, we're sadly not as quite as diverse ethnically as other places. So I don't tend to see a lot of darker skin types anyway. But no, I don't think I've seen it beyond a skin type 3. And obviously within a skin type 3, you can get lighter and darker skin type 3. But no, I haven't actually seen it.
Yeah, it's more difficult to treat because because clearly we need to keep our settings down because of the, you know, the additional melanin in the skin.
Absolutely.
So yeah,
you've got competing chromophore then, so targets of colour. So you're trying to treat the red, but not actually pick up the melanin in the skin, and so it's a constant balance between, you know, doing an effective treatment on the target but protecting the tissue. So yeah. In fact, I don't think on the Lumina you can do a vascular beyond
beyond 4.
No, beyond 4 anyway.
Yeah. And even then, very, very, you'd have to be very cautious. Very careful.
Yeah, absolutely.
So you sort of touched on the fact that there are these different types of rosacea. So you've got erythematotelangiectatic rosacea. It's a bit of a mouthful, but it's basically just this sort of red, veiny rosacea. So that's kind of, I think, what a lot of people tend to think of when they think of rosacea. So people who will have this sort of permanent redness, they'll flush very easily. They'll almost always, as I said earlier, have some small vessels on their cheeks, on their chin, on their nose. Then there's the papulopustular rosacea, and sometimes people kind of predominantly have this more than the veins on occasion. It's different to acne, as you say, in that if with acne, with the traditional sort of acne vulgaris, you'll also have some comedones, so you'll have some blackheads, some whiteheads, and we don't tend to see that with rosacea. So they're not, as you say, they're not sort of the pustules are not full of sort of like they would be with acne.
Yeah.
Then there's the thymatous rosacea. So this is where the skin starts to thicken. So especially on the nose and on the chin, really, in the sebaceous areas. And it can develop into something called rhinophyma, which is where people get these very enlarged noses. I mean, I've seen some cases of rhinophyma. So you can get something called mega rhinophyma, where the nose on one chap I saw was actually lower than his chin.
Oh,
I don't know how, it was essentially completely isolated for years and years. He wouldn't leave the house because of this. So and that can be treated with things like CO2 lasers, but of course your IPL is not going to help with that sort of condition. And then there's ocular rosacea. So people with ocular rosacea just have constantly very dry eyes, feel like there's something in their eyes quite often, and that can be really unpleasant as well. They'll often have all of the other symptoms as well, but it's worth bearing in mind that people with rosacea can sometimes present with eye issues as well because of this.
Yeah.
So causes. So this is kind of traditional here. You've got the sort of papules and pustules on this lady and that permanent redness. Do you want to talk us through some of the causes?
Yeah, so with my clients, the causes over the years have been so vast, like it's so different. So obviously there's the hereditary factor, but obviously stress, the typical causes, I always ask people whether they know what their triggers are, which I think we're going to come on to later anyway. But for some people it's sun, for some people it's, so these are obviously triggers, but the reason why they have it in the first place is not really known other than, the hereditary factors. But I always go through with people, do they know what their triggers are, whether it's caused by sun, alcohol can be a cause. So with the bulbous nose, people often think that they're, alcoholics, but obviously it's not related to alcohol, but alcohol does definitely exacerbate rosacea for a lot of people. It can be spicy food. For one of my clients, we found out it was MSG, so monosodium glutamate, which is a horrible flavor enhancer, which I avoid like the plague, but it's really bad for things like eczema, psoriasis, and also for rosacea as well for some people.
And does she figure that out by keeping a diary?
Yeah, so I get my clients to keep a rosacea diary. These are for the people who really don't know what their triggers are. For some people, they come in and they say, oh, every time I do this, I flare up, this happens. Other people are like, I just don't know what it is that causes me to have my flushing and blushing episodes. So yeah, that came down to one of the diary keeping sessions that she did. But another of my ladies, she was quite elderly, and basically a lot of her friends were dying because they're in their 80s, and it was emotional stress that was causing her rosacea flare-ups. And obviously that's something that you can't control, like you can avoiding MSG or things like that. So yeah, it's very varied from person to person as to what causes their rosacea, what causes their flare-ups, and with that comes how they manage it, because that obviously differs from person to person as well.
Well, Verity here has asked a question about how much do you feel it's lifestyle driven, and absolutely, I think we're about to talk about it. Oh no, we'll come on to that in the next slide. Does anyone know what this charming little creature is he's a demodex mite. So apparently people with rosacea have something like 18 times more of these living on our skin. We all have them. We pretty much all have them to a lesser or greater degree. And there's some debate as to whether these things can cause rosacea, or if it's the fact that if you have rosacea, it's you have sort of perfect conditions for these to breed. But it's definitely the case that people with rosacea tend to have more of these demodex mites. So they live on your skin, they live in your eyelashes. Apparently they don't have an anus, so they can't defecate. So they basically keep on eating until they explode. And then, then you've got all that in your pores and all sorts of pleasant things. So
Lovely.
so there are some treatments that can help to reduce the number of these things. As I say, we all have them, so it's not that we have to treat them or get rid of them particularly.
No, they just go into overdrive in certain conditions, don't they? So
yeah. But yes, Verity, your question about lifestyle, I mean, avoid your triggers is really important. I don't know if anyone's seen Alex Ferguson since he stopped managing Manchester United, but his skin has improved so much because the triggers, things like temperature extremes, strenuous exercise, stress, anxiety, cold winds. If you're a football manager, you're pretty much, going to be facing these on a daily basis. Sorry?
You've got all your triggers there if you're a football manager, but I wonder if he'd ever had laser treatment though.
Well, I wonder that as well, because there's been quite a bit of improvement. Yeah. But certainly, as you mentioned, alcohol, red wine in particular, curries, spicy food. Lots of people will know as soon as they have a sip of, alcohol, they'll get that flushing. Chemical peels, microdermabrasion. Now, I know we spoke about chemical peels earlier, didn't we? And we've got a question here from someone asking about other treatments. If you don't, I'm laughing at Heidi's. Heidi's put a comment saying that's going to give me nightmares.
Verity, she can't see me because can no one else see me either?
No, I think that's fine now. I think that was okay.
So in answer to the question about lifestyle, I think that plays a massive effect on your rosacea. But sometimes, some people can do everything right. They avoid alcohol, even though they'd love to have a glass of wine on a Friday, and they wear their sunscreen, and they're not particularly stressed, and for some people it's just they do everything right and it's still an absolute nightmare for them, and other people can manage it really effectively by simply cutting out a few of their triggers. So it varies hugely, and in my clinic I take very much a holistic approach, because it's not simply someone comes in, has treatment and off you go. As we're probably going to come on to anyway, it's not a cure, but it is an amazing management system, and I have absolutely loved treating rosacea over the years because it is so effective at helping to manage. But the client has got to play their part. Same with acne treatments, they've got to play their part to get the results that they want. So I do go into a lot of in-depth with them about how it affects them, what their triggers are, etc., so you can get the right outcomes that you want.
I think your point about it not being a cure is really critical. So this we don't know what causes it. We can't cure it. This is only management, and it's really, really important that our clients understand that as well. So it's not going to be a case of you have a course of treatments and you're cured of rosacea. You're always going to have to continue to manage it, really.
Yeah.
If you go to the GP, they'll usually give you antibiotics, and they can be very useful for some people, especially if you have the papulopustular rosacea. It can help with that. If you've got lots of thread veins, then the antibiotics aren't really going to do anything, but they can minimise some redness as well as treating.
Yeah, I think my issue with the antibiotics is that I've had people come in and say, my doctor said I have rosacea, just because they have broken veins, and that's part of our job as clinicians, is to really not just assume that just because, no disrespect to GPs at all, but not to just assume because a doctor has very quickly said to them you have rosacea that they necessarily have it, that you need to go into in depth in the consultation with the questions as to establish whether you know, they actually have rosacea, or they just have broken veins, because I have loads of people who come in for IPL treatment with a 585 handpiece who, you know, have lots of redness, but they don't actually have rosacea. You know, rosacea is a very debilitating condition. It's not just an aesthetic kind of, you know, you've got some broken veins on your cheeks that you don't like that happen to get redder when you drink wine. That's not the same as having this condition. So
yeah. Cilantro, have you come across that quite more increasingly, I guess, now?
So I have a client who happens to be a GP with a special interest in skin. So like my other friend who I know is watching now, who is a natural dermatologist, we're complete geeks. All we talk about is skin. And she actually said to me, this client, she talked to me about cilantro, and she said that they were trying to get the word out to GPs just a few years ago. So this is when it was first coming on the market to treat rosacea that is caused by the demodex mite. So if I get someone in who looks very inflamed, I can't really describe it, but rosacea that's often caused by or is providing the right breeding ground for the demodex mite can look quite different to standard rosacea. And so I tend to always send them back to their GP and get a prescription of cilantro just to rule that out. And I did have someone recently who came in and I said, I think it looks like you might have this mite. Then you have to go through the whole thing about what this mite is, because they're horrified.
They show them scary pictures.
Not only are they coming in with their inflamed face, now you're telling them it's actually caused by the most, you know, disgusting looking mite. But you know, and then, you know, he came back and he was like a different person, and he ended up having a few vascular lesions done around his nose as a result. But his entire face looked, he's like a different person because of this ivermectin, which is basically called the common name is cilantro. So I tend to rule that out first before trying to treat them with laser.
And will you treat people if they're taking that, if they're using that?
No, I let them, I wouldn't treat them whilst they're on it. I don't tend to treat people when they're using any kind of topical sort of medical creams at all. So no, I would wait. And also there's no point, because if they're on it, you're trying to see if you're going to get rid of the mites anyway. So I would wait, see if it's done its job. If it hasn't, leave a certain amount of time between them stopping taking it and then using it, and then start a laser treatment.
Yeah, I would think a week or even potentially a few days is probably fine.
Yeah,
you know, it's not particularly photosensitizing or anything, but nonetheless, you're absolutely right. Let it do its job, and then you know, tidy up, I guess, with the laser and IPL afterwards.
Yeah, exactly.
Just looking at questions. With the use of antibiotics, can IPL treatment still be done? Yeah, that's a really good question, Abby. Oh, and Tina, I'll just answer this quickly. The mites are called demodex mites. So yeah, Google them. You'll see lots of, of awful pictures like that. Antibiotics. So the antibiotics that they tend to prescribe will be metronidazole, which is fine. That's not photosensitizing. But minocycline or other tetracyclines are often prescribed as well. Minocycline is contraindicated. The reason for that is because it can cause pigmentation changes in the skin. Usually it's for oral, antibiotics. So if it's topical, that's not quite as common. But nonetheless, we wouldn't do treatment on someone who's taking minocycline. So the medications that are contraindicated are basically all the ones that will be on your consultation form and all the ones that are outlined. But we use the British Medical Laser Association guidelines for this. And so there are just a few really. So things like Roaccutane, minocycline, amiodarone, St John's wort, there's not that many. Nonetheless, if someone is taking a topical, using a topical ointment that the doctor has prescribed for their rosacea, I would basically let them finish that course before going on and doing treatment.
Yeah. And also, because I know from my perspective, I want to know which actually did it for them,
Yeah.
I want to know that whether that actually worked, because then it's really good to be able to tell other clients as well, or whether the laser actually got the results, so that we actually know, what works for people. And it will be different for every person. So I think when you're combining things, it just confuses the outcome. You don't really know what actually worked in the end.
Yeah. It's worth thinking about differential diagnoses. So as I mentioned earlier, we're not, you know, if you're not a medic and you're not quite sure what's going on, then do not treat. You know, there are other things that can present with red facial rashes. So there's something called polycythemia, cythemia vera, which is basically caused by increased number of red blood cells, and that presents with a red rash on the face. Connective tissue disorders like lupus, scleroderma. Sometimes there'll be rashes, bigger rashes all over the body, but sometimes you can just get this sort of characteristic sort of butterfly rash with lupus in particular. Sometimes it can be due to photosensitivity reactions, topical steroid use, or contact dermatitis. So there are, you know, a lot of things that it can be. As you mentioned, Kerry, it can just be telangiectasia. It can just be red veins on the face, not necessarily rosacea.
Yeah, absolutely.
So, do refer people back to their GPs. If it's very severe, you know, tell them that to ask their GP for a dermatologist referral as well.
Yeah. And this is where how thorough your consultation is and how much time you put aside for consultations. In my clinic, I put aside an hour, and if I think they want to talk to me about a few different things, it's an hour and 15, because it's taking the time to really establish what's going on for that person that's going to determine, you know, the course of treatment to take. So I sometimes hear about clinics doing 20-minute consultations, and it's just not enough time, especially for skin. So yeah, so that's really crucial, just to establish what it is you're actually dealing with.
So consultation tips, let me just check the questions before we, so use of antibiotics, yeah, with most antibiotics it's fine, but not minocycline. Mites are demodex mites. Topical antibiotics, is there much difference between cream and gel? I don't know the answer to that, Verity. I can't imagine that the different formulations, there'll be certain reasons why some are gel form and some are lotion form. I don't.
My friend, who shall remain nameless, is a dermatologist. Perhaps you can just message the panelists and let us know what you think about the difference between creams and gels for antibiotics. You know who you are.
Okay, so yeah, tips. Tell us what you do in a consultation then. If you have someone in for rosacea, how do you go about doing that consultation?
So generally speaking, you get two types of people who come in. It's the people who know everything there is to know about rosacea, because compared to when I first opened 15 years ago, where it was, you know, yellow pages to find a laser clinic, now they've got Google, and clients are so much better informed about, you know, their own conditions. And it's like anything, if you have it yourself, you become almost like a complete expert on it, don't you? So there are other people, however, who I've only literally just heard about laser, that it's possible to treat. They don't really know why they're having the redness. So again, I kind of take the same approach with everyone. I sit down and just let them talk, and just first of all establish, you know, if they even know what they have. Some people just think, you know, why is my face red all the time? Other people just want to dive straight in and say, right, I know this is what I have, and I want to know what laser can do for me. So first of all, I establish how much they know. And then the next point is to kind of try and talk to them about the condition as well. And this is what I would say to all clinicians. If you're advertising as treating rosacea, I highly recommend you really do your homework over and above sort of just treating it with laser, because the more informed you are about their condition, which clearly is very distressing to them, the more confidence they're going to have in you, that, you know, you're the person to treat. So I don't know about you, but I hate it when I actually go somewhere for a problem. I hate when I sit there and think, oh my God, I actually think I know more than this person who's the expert I'm supposed to be talking to. So yeah, so really get clued up on rosacea, the condition, and then talk to them about it, and then ask them questions, you know, find out, you know, do either their parents have it? And if they say no, what about your grandmother? Because sometimes our people say, oh, do you know, my grandmother always had a red face, you know, she never used to moan about it. It was kind of the back of pre-war, you know, stiff upper lip and carry on and all that. They didn't used to kind of, you know, talk about their skin issues, clearly. But so I try and establish how much they know, fill in the gaps of what they don't know, and then assess whether it is going to be appropriate for them to have treatment. So if they're extremely inflamed, or I suspect the demodex might, or I think you pronounce it demodex might, I would send them back to their GP. If they've already seen a GP and they've said, yes, it's rosacea, and you think it's rosacea as well, I would start to talk to them about course of treatment. But if it's very inflamed, I actually put them under some LED phototherapy first. So like a near infrared light to get that inflammation down, because if it's really inflamed, the last thing you want to be doing is actually putting a laser on them. So it needs to be at that level where it's not so uncomfortable and burning and itching, and they can barely touch their face, so that you can actually start to do treatments on them. I go through their skincare with them to try and see if it's anything that's actually, causing their irritation, their diet. I give them a rosacea diary if they don't know what their triggers are. Some people say, yep, I know it's this, this, and this. They're already trying to manage those triggers, and so your job is just really to take them through a course of laser treatments. Managing expectations is absolutely key. I never really get any clients who are really upset or disappointed with treatment, and that's not because I can do everything 100% all the time, or I can give them the cure or get rid of their acne. It's because I am very, very honest about expected treatment outcomes, and get them to work with me as well. So people are always, they leave the clinic knowing full well what the score is, what they can expect, what they have to do to help with the treatment as well. So yeah, that's generally how I sort of manage things.
I think that rosacea diary is a great tip.
It's brilliant. Yeah.
So, and didn't you say that you can, that there are templates you can download even on the
so basically, so I discovered, so back in 2005 I discovered rosacea.org, which is an American website specifically on rosacea. Back then they used to send like sort of printed newsletters all the way from America until it kind of all became online, etc. But on there is a rosacea diary. I think if you Google rosacea diary, rosacea.org is the first thing that comes up, and it's really simple. It's every day. It's just a tick box, what the weather was like, what you ate, if it was spicy food, how you're feeling emotionally, and any skin products that you used. So I've just had an answer from my lovely friend the dermatologist. Okay. Gels are transparent and are usually absorbed faster compared with creams. However, it depends on the individual antibiotic preparation, concentration, etc. So there we go. So I guess depending on the strength of the antibiotic and how quickly it needs to be absorbed, I guess would determine if it's going to be a laser cream.
The vehicle of delivery probably isn't as critical as, people will just have preferences, won't they? What they prefer.
Yeah. And I wonder if it comes down to also how maybe oily their skin is as well. If they're perhaps
Gels are nicer for,
So thank you for that.
So treatment tips then. How many treatments are you generally doing?
So for any vascular treatments on the face, I always say to people to expect to do between 3 to 6 sessions. That's for a course. But as we know with rosacea, it is an ongoing condition. So I always say to people to absolutely not count on any less than 3 sessions, spaced at about 4 weeks apart. But in reality with rosacea, you're going to be probably using the full sort of 3 to 6 sessions, and then have some top-ups and ongoing treatments. So, but to be honest, people who are really suffering with the rosacea, they're quite happy with that. They just want to know that there is kind of like an end in sight in terms of just giving them some, to alleviate the symptoms for them. So yeah, about 3 to 6 sessions.
And you tend to combine, as you mentioned, with your LED. Verity asked what LED you use, and it's the Dermalux system.
Dermalux, yes.
Which we have in our clinic as well.
Yeah, it's absolutely fantastic. So it's amazing for all manner of things, all kinds of skin rejuvenation. It's for eczema, psoriasis, and it's very, very good for redness as well. So if someone, sometimes, because obviously there's quite a price difference between Dermalux and laser, clearly, and people sometimes say, oh, well, can I just have the Dermalux? Now, if they've got loads of thread veins on their face, the Dermalux is not going to get rid of thread veins. You know, to get rid of a vein, you have to coagulate the blood. You've got to heat that blood, coagulate it, and let your lymphatics, so all your white blood cells, do a clearing up job. That the LED is not going to do that. But what it is really good at doing is helping to reduce the redness. Just, you know, when people get kind of just redness, you can't actually see any actual vessels. Although having said that, when people are presenting with rosacea, although it is much more difficult to treat, because there is still blood there, I do actually still treat them with IPL, but I combine it with the Dermalux as well.
So what techniques do you use? Do you just go in with a medium-sized block? I'm assuming you're using your lumina for most of these. So if you're doing a lumina treatment, talk us through how you carry that out.
So it's funny because I know I can see Jill's on here today, and Jill and I have, for about 15 years, have talked about the medium and the small block. I'm very, very cautious using the medium block on the face for vascular. For acne, no problem, because obviously the settings are much lower. But there is actually a slide that's coming on in a bit, which is one of my clients, and it was that client who I did end up actually bruising. And it was fine, because at the end of the day, as we all know, if you do ever get a bruise, the results are amazing. So, you know, because obviously it pops the vessels, like a bit like a pulse dye laser would, I guess. And so the results are amazing. But in an ideal world, you don't really want to bruise people necessarily. Now, she had a lot of target, and this was in my early days. You learn by your mistakes as such. And although it wasn't technically a big mistake, I still, ever since that, would prefer to use the small block. Now, if you get someone with a lot of target, you know, it's really thick, dense, a lot of thread veins, I would always start with the small block. But, you know, I have treated people, you know, when you get rid of the vessels and you really are getting rid of the last few, and you're trying to get a bit of a rejuvenation treatment in there as well, then I always use the medium block on there. But it has to be, I would only use it probably for skin up to skin type 2. But again, you know, it's whatever you feel comfortable with. And from my experience, I prefer not to use a medium block unless it's up to skin type 2 and there's not much target there, basically.
So I think we're the same there, Kerry. I would tend to go in with the smaller block first and just get rid of as many of those sort of obvious vessels as you can. And that means when they're coming in for their next treatment, you've reduced the amount of target in there, and then you can go in with your medium block. But if someone's got lots of vessels, lots of target, I prefer to use the small block to start off with.
Yeah, absolutely. Yeah, and what I love about Illumina as well is the little round one. So the little, imagine a small square block. I don't know if everyone on here has it.
Possibly not, but it is still available.
It's fantastic. Imagine your small square block, centimetre square, and draw a circle inside, so you can get all around the corners of the nose without digging the kind of the pointy square bits into the skin. So yeah, I absolutely love that. Like it's like my little magic tool.
Got some questions, let's have a look.
Sorry, I'm not looking at the questions. So
right. Heidi, you mentioned pre-printed diaries, so we use the one on the Rosacea org. Management treatment then, how often do you do management top-up treatments?
So again, it really comes down to how you need to build that relationship with the client to manage expectations and for them to understand that it's not a cure and they will have to come back in. So they tend to basically contact me whenever they leave. So they've had a course of treatment, they're really pleased with the results, it's under control, etc. I always have that conversation to say, look, you know, if you feel like you're starting to have flare-ups, if you see a little bit more redness, don't wait, don't let it get, you know, because sometimes people say, oh, shall I wait until it gets really bad again and then come in? It's like, no, it's much easier to manage the condition by not letting it get really bad, and in the meantime they'll just be experiencing unnecessary discomfort anyway. So so it's always, you know, making sure that when they leave your clinic, they remember, you know, call me anytime, let me know how you're getting on, drop me an email or a text, etc. And do come in as soon as you feel like it's starting to get a little bit, you know, running away with you. Come back in and let's get you under the laser again.
I agree. So it will vary, won't it? From you know, so some clients might have one top up a year. With others, they might be coming in every 3 months for a top up.
Yeah, absolutely, exactly.
Look at some more questions. Do we diagnose a condition, or do you require a diagnosis from a dermatologist? Well, we don't do any diagnosing. You know, as non-medics, we shouldn't be diagnosing anything. But nonetheless, with something like rosacea, it is relatively simple on the whole to sort of say, yes, that's probably rosacea. But if you're unsure, then you should always, you know, make sure that you get them to pop in. And a lot of the time people know what they've got, you know, they'll have had a diagnosis at some point.
I think the bit about, I mean, yeah, I think the important, I mean, say for example, you had someone in and you came to the conclusion together based on a series of questions that, you know, they had rosacea and it wasn't rosacea. At the end of the day, what's the worst thing that you've done is you've actually treated a load of thread veins. That the reason it's so important to establish whether it is actually rosacea comes down to that sort of educating the client and helping them understand that they have a condition that will necessitate further treatments, that it's not a cure. Not that thread veins per se is a cure anyway, but that's why it's important to, and yes, we're not, and the one thing I was saying, because we tend to wear white tunics in clinic, and it's amazing what people tend to assume just because you're wearing a white coat, you know, that we always say, look, we are not medical, we are not diagnosing, it wouldn't be appropriate, it's not our job to do so, but we know enough about this condition to ask the right questions as to whether, and at the end of the day, if it isn't rosacea, brilliant, after the course of treatment they won't be back for a very long time. So yeah, I think it's really important to be very clear and open with clients about, you know, who you are.
We've got another question here about topicals, so about home care. So it's certainly true, isn't it, that good home care can make a difference as well for people. What do you recommend?
So because obviously what you do at home and what you do at home twice a day is sometimes almost more important than what you're actually doing in clinic. You know, it's not, you can't go to the gym once a month and expect to, you know, have an amazing toned body unless you've got an so you know, you have to do your bit at home as well. So I always I actually get clients to bring in all their skincare. Sometimes they arrive with a massive bag, you know, of all this stuff that they're using, because, you know, we all cake our skin in stuff unnecessarily, actually. So again, it's about sort of re-educating people, not in a patronizing way, but in a genuine, you know, this is actually what you could be doing to help at home. And I always put them on really good skincare.
And a good sunscreen just by itself can make the difference. Yeah.
So I unfortunately have melasma, and I've had it for years, although it's not really visible anymore because of the treatments I do. If I go out in the sun 10 minutes, it comes back. So I'm really hot on sunscreen. And also at the clinic, I always say to people, look, prevention is better than cure. And I'd much rather sell you a sunscreen than trying to be reversing sun damage. And again, it's building that trust with people, that you're not just trying to flog them treatments or trying to do treatments unnecessarily, that you do genuinely have their best interests at heart. So sunscreen is absolutely key. My friends take the mick out of me all the time because I'm always going on about, have you got your sunscreen on? So it's the same in clinic. You know, I treat my clients like I would treat my friends and family. Sunscreen is absolutely key. Lynton do a fantastic one, an SPF 50. I also use a Vitage one, SPF 30 as well. But sunscreen is absolutely key. So, but yes, I put them on really good skincare, and then I basically tailor a plan to their budget for how often to come in for whatever course of treatment we've decided is going to be the best course of action for them.
Heidi's asked about the range that we use, the skincare range. So I know at the Lynton clinic we use Image, which seems to be nice. Obviously, we combine that with all the Lynton skincare bits, but if people need specific skincare for, you know, for acne or for redness or whatever, then do you use Giammarini?
Yeah, I've used Giammarini for about 15 years, and I use it myself as well. I absolutely love their products. I also love the Lynton stuff as well. So we've got the triacid peel that I use, the stem cell lotion. Obviously, I've got the God, I've got my head, the soothing. The
Light Soothe.
Light Soothe.
I think
Light Soothe.
I mean,
Either way, I was going to say it's amazing for your hands at the moment, because
Yeah.
all the hand washing, the light soothe is amazing because obviously it's got hyaluronic acid in it as well, and so it retains water. So yeah, so I think it's important in your clinic to have a few different types so that you can pick and choose and tailor, you know, because not everyone is going to fit the same in the same box. So
even even if it's just light soothe, that's a really nice moisturizing light lotion that will help with someone who's got very inflamed skin. So even if it's just that they go and they take some light soothe and use that as their daily skincare,
yeah, absolutely. And sometimes that's the only thing they will be able to. It's got nice things like Manuka honey in it as well. So, and you know, this is the thing. I mean, people do tend to want to come in and have a quick fix because they're in discomfort. But it's about kind of talking to them and doing it step by step and saying, well, we actually can't throw everything at it yet. We need to get your skin a bit calmer. We need to hydrate it. We need to protect it from the sun. And so you build, and you end up with, you know, with a really loyal client because they can see you're not just trying to take their money and run.
So some pictures here. I mean, just one treatment can make a difference. This is just one treatment, quite high settings, but you know, a good reduction in the erythema just after one treatment. This is a lady that I treated. This isn't a great photograph because the white balance is a bit off, but I think you can still see that, you know, after a couple of treatments, real reduction, especially in that sort of panda eye effect that she had. You know, her skin tone is more even following just a couple of treatments. So she still comes into the clinic and has treatment, you know, just when it flares up, but every couple of years or something probably. But oh yes, but I mean, it's also worth mentioning telangiectasia, I think, because, you know, if you're treating rosacea, you will be treating some thread veins as well. So they can be associated with things like, you know, just general aging, photo damage, hormone changes, so pill, pregnancy, all of those things. Rosacea, certainly, as we mentioned. We talked about the role that alcohol can play. You know, alcohol is a vasodilator, so if you're prone to flushing and thread veins, then, you know, some people find that it helps if you can avoid it. Facial vessels, I mean, I never make any guarantees with any treatments, but I've yet to see facial vessels that I haven't been able to treat with one of our IPL systems. You know, they do respond very, very well to treatment. Leg veins are more difficult. So leg veins are much more unpredictable, and that's because they're under higher pressures, the vessel walls are thicker. Sometimes you can see you're doing the treatment and the vessels will seal up nicely. You stand up, you start walking around again, and those vessels will open up. There's often feeder vessels that can, you know, just cause them to come back as well. So leg veins can be more difficult, but we've got some pictures here. So this is immediately after a leg vein treatment. So it's looking a little bit red and a bit angry, but you can see that instant, that instant change in the vessel, and that's really key, isn't it? When we're treating vessels, facial vessels, leg vessels, whatever, they need to change when you're doing that treatment. They need to look different. They need to either blanch, or in some cases they'll darken. They'll sort of go a brownish colour as you coagulate the blood within the vessel. But if the vessel looks exactly the same after you've zapped it with the laser or hit it with the IPL, then it probably hasn't worked. You probably need to take the settings up a bit higher. Well, this is one of yours, isn't it, Kerry? Do you want to tell us about this patient then? Oh, Kerry, have I lost you? Kerry, can you hear me? I don't know if that's my end or Kerry's end. But I know that this is one of the people that Kerry treated, and for IPL treatments, I don't know if this person that there was some bruising. We might come back to this one, but you can see a gorgeous result there with the vessels. Another one before and after treatment. Kerry, are you back with us?
I'm really sorry, just internet unstable. So yes, sorry, you said that was one of mine.
We were just talking about your client here.
Yeah, this is the lady who came. You can see from the sticker it says 2006. So this is the lady who I did end up bruising because I used the medium block on. She had amazing treatments. I so wish she'd just come back and had one more, because as you can see, there's you. I'm just, obviously I always stop when people are happy, but as a clinician, you're thinking, I just want to get those last
But she must have been delighted with that, though, I guess.
Life. Now, she was someone who came in, my GP says I have rosacea, I've been put on antibiotics, etc. And actually she didn't. And, time is testimony, because she hasn't been in since 2006. But I actually rang her a year ago. She was very outdoorsy, had horses, and it was purely, being in the, she was in her 40s at the time. She'd been outdoors, since her teens with horses. So it was very much environmental, never wore sunscreen. So yeah, and the results were fantastic. And she said she used to spend all her money on concealer. And because of the amount of heat that the vessels used to bring to the cheeks as well, she said the concealer never used to stay on very well. It was just awful. And she wasn't someone who particularly, wore lots of makeup, or she just couldn't stand this redness in her face. And so she was absolutely chuffed to bits. So yeah, but yeah, I would definitely, if someone comes in presenting with this amount of target, I personally wouldn't use a medium block on it.
I've treated ones like this with a medium block in fewer treatments, in maybe 1 or 2 treatments. But I treated a chap once, very similar, and he had so much swelling afterwards, so much puffiness, that he said that he couldn't drive for a couple of days. So so you can get the same results without being as aggressive. Just take a few more treatments.
I would say as well that the larger someone is, the more sort of fluid retention they have. And I treated someone a few years ago, and obviously you don't see the clients the next day normally, and this person was staying with me, and she was extremely large, and the next morning she got up, and honestly I was so shocked. And it was actually a really good thing for me to see. I have never seen swelling. It looked like it was blisters under her eyes. It wasn't blisters, it was just fluid. But she was, a large lady, and so it's a really good thing to remember to tell people, obviously very delicately, that they may get some swelling, because it was really quite shocking to me, who'd been doing treatments for a long time, to see just how much swelling you can get, because obviously we don't go beyond the eye bone, but the swelling was actually between the bottom of the eyelids and the eye bone. So obviously the swelling had travelled up, so clearly it wasn't even an area I'd actually lasered, but you can get a lot of swelling. So the more you prepare your client, I always prepare my clients for worst case scenario, and I'm telling them it's worst case scenario, that I'm not expecting all this to happen, so that they're not shocked when they wake up the next morning looking
a couple of additional pillows as well can really make a difference. So if they can sleep a little bit more upright, that makes a difference. That's why it's always worse in the morning.
And timing of the day. So if you think someone's going to swell, try and get them in the morning when they're going to be upright. Don't do it as your 7:30 p.m. in the evening appointment, when they're going to go straight to sleep. All those little things kind of help.
So just some more examples there of some thread veins / hard to tell whether that's rosacea as well, probably just vessels there actually.
Again, it'll come down to the questioning of the consultation and things. So but, I agree.
Little spiders then, so these are, so rather than sort of thread veins that we have that run across the surface of the skin, these kind of come up perpendicular, and they sometimes have these little legs that radiate out, hence the name. Very common in children as well, so often on the face, the hands, the trunk, the arms. Very common with hormonal changes, so I had loads of these pop up during pregnancy. But if someone does have numerous, lots of these, more than 7 or so, it can sometimes be associated with liver failure. So just, if someone comes in and says these have just all popped up recently and it's not a hormone related thing, it's worth suggesting they go and chat to their GP.
Especially on this area, I've heard. Have you heard that, Sam? On the décolleté, I've heard that if you get a lot of them burst spider nevi, that it can be associated.
It's certainly quite common to see them there during pregnancy as well. So, but we can treat these really easily. They, one zap with an ND-YAG, with an IPL, with a diode, we can get rid of these. And they'll tend to either blanch immediately, or more often, in my experience, they go sort of brownish, and then the body just reabsorbs them over the next few weeks. They can sometimes be confused with these Camden Morgan lesions, but these tend to be on the torso, tend to be in older people sort of 40 onwards. And they're just a little overgrowth of tissue, so a little benign tumour. I don't say the word tumour to people because obviously people get concerned, but completely benign, completely harmless. These, when you treat these, they go really dark immediately. So they go from being really bright red to looking really dark, and again, the body will just reabsorb those. So the difference between those and a spider is that if you compress a spider nevus, it will blanch, whereas these ones won't. So if you compress it or if you stretch it, it will blanch.
Yeah.
And then finally, then, just to finish off, Poikiloderma of Savat, because again, this is a condition that can be talking about red rashes. Sometimes people might think that this is related to rosacea. It occurs on the neck. It characteristically will have this sort of shaded area here where it's really aggravated by sun exposure. And because this area is shaded by the chin, it tends to not be as pronounced here. If someone has this, then you can treat it with IPL, and it's very effective, but it's a very delicate area. So it's only a treatment I would do in the winter months, really. People, even when people are good at putting their sun cream on, they often forget to put their neck on, to put it on their neck. So if someone has this, regular sunscreen is really important. Minimise perfume, cosmetics in the area, even jewellery, and you can treat it, but I would do it, as I say, don't do it in the middle of summer because it catches a lot of sun in those areas. Have you treated this, Kerry?
I have. I'm always very cautious with Poikiloderma because it can present either as vascular or pigmented, and sometimes a combination of the two. So depending on if it's purely vascular, then yes, absolutely. And I've had amazing results treating with that. But with the pigmentation, if it's more dermal, then you can end up making it 100 times worse. So you've got to really be careful as to which you're dealing with and have a really good look, preferably under a mag lamp.
You'll see the textural change as well with this very often, because you get that sort of crisscrossy effect.
Yeah,
that's quite common to see with
but people often think it's because they've sprayed perfume on it, and quite often with perfume and going in the sun, it can make it worse. But you can get some really nice results using this, and obviously on that area, depending how bad it was, I do tend to use the medium block, otherwise you'd be there forever.
Low settings, low settings, medium block.
Yeah.
Okay, that's the end of our slides, but we've got some questions that we can go through.
I just want to go back quickly. Someone, Colette, asked about which light I would start with I'm assuming that's obviously with the Dermalux. If it's very inflamed, Colette, I would stick them just under the near infrared because that's very anti-inflammatory. And then I would work up to using the red on them as well. So, yeah.
Right. Other questions here? What have we got? Ashling's asked, the small square block or the small round, is there a difference? They're just, so as standard with the Lumina, the Exolite, the Luminette, you get a small, medium and large rectangular block. With the 3 Juves, there's also, you get as standard a round one, and you can get that with the Lumina as well. I can't remember the price of it. I think it's, if anyone wants, someone here has asked for the price. I can't quite remember it off the top of my head, but I can let you know. If you email clinical@lynton.co.uk, I think it's about 150, something like that.
It's well worth the money. The difference, I wouldn't use the small round one on the cheek. One, because you'd have to do an insane amount of overlapping. If you imagine trying to fill an area with circles. I wouldn't use it. But if you're doing a spider nevus and it fits perfectly, then sometimes I will just use the little round one. But generally it's amazing for the corners of the nose. You can really get in there without digging the corners of the square block into the person's skin.
Nice for lentiginous on the hands as well. Katie's just put a comment saying, I've just bought the small round block, it's amazing.
Yeah.
Someone else is a fan, good. Tina's asked, can clients have any kind of chemical peel to help with rosacea?
Yeah, so I definitely do glycolic peels on rosacea clients, but again, not on anyone who's very, very inflamed. And I only use products that are recommended for rosacea conditions. So January, do a whole range of products for redness and for rosacea. So I feel very comfortable, using those. But yeah, people often think that they can't use glycolic, for example, on someone who has rosacea. But I find the more you get rid of the dead skin on the surface, which if you magnified your skin to sort of 20,000 times, you'd see great big flakes sitting on the surface, and you've got to think that the light has actually got to penetrate the dead skin cell, and there'll be a certain amount of reflection from that, wouldn't there, Sam, as well?
You get a lot of reflection, scattering.
Exactly. So if you get rid of that and you literally have almost squeaky clean skin, the light just penetrates that much better. I know, for example, I know we're not talking about acne here, but when I do acne treatments, when I say to people it's 4 to 6 treatments, if they're interspersing it with glycolic peels, they end up having only 4 treatments rather than the full 6, because the light works so much better. And it's the same with rosacea. So definitely get them on a glycolic at home if their skin will tolerate it. Obviously, again, it's about building blocks. It's building them up to what they can use.
I think there'll be some glycolic formulations that will be too aggressive for rosacea.
Absolutely.
So as you say, it should be one that's been designed for use.
Yeah, absolutely.
Skins.
Yeah, exactly. And it's getting them to use one at home first to build up before you would even do an in-clinic one anyway. So, but yeah, I would definitely recommend using glycolic or a glycolic range for rosacea. Just want to see this other. What's the wavelength of IPL for rosacea? Does it depend on the size of the vessel? So no, so I use the 585 handpiece. It's 585 nanometers, and that's what I use for treating vascular, pigment, acne as well. So yeah, so
the range that gives is so we call it the 585 handpiece, and it gives out light from about 550 to about 1,100 nanometers. So it's broadband light.
But it's mainly concentrated. You get more of the 585, don't you? So it's not like a laser, it's a direct, it's only 585, but you get more 585.
You get more at the shorter wavelengths. Yeah, absolutely. Katie has just informed me, thank you, Katie, that the round block costs £230 plus VAT. She's just got one. She's asked how much the Dermalux system costs. I don't actually know that.
I think they're about 16 grand. So yeah. I think they're about 16.
Don't quote us on that.
Don't quote me on that, no. So we've got a question from Colette. If I was starting a client with just vascular over the face, I'll probably normally start with 24 to 20. Is that too low? I don't want them to swell or blister. What would you start with in what setting? So it completely depends on the skin type. So the lower the skin type, as in a 1 or 2, the higher you can treat. You need to, obviously, it's a combination of skin type, of how much target they have, how much vessels they have, and obviously the lumina will guide you anyway as a starting range. But in your patch test, that's why the patch test is so key, because you need to use a range of energies so that when they come in, you're actually doing an effective treatment. So you're looking for those clinical endpoints like the blanching, the reddening, a change of color in the vessel possibly. So because sometimes they can actually, if you do treat them quite aggressively, they can actually sometimes go grey. Not recommended particularly, but you can't always be in charge of how much energy that vessel is going to absorb. So obviously you can dictate how much energy you're going to deliver, but sometimes there will be the odd vessel that you think, wow, that actually absorbed quite a lot from that fluence of 22, which isn't even that high. So assess your client for skin type. Look at how much target they have. So obviously that picture of the client where we said, I bruised her, I'd be starting very low. So 20, 22, maybe get up to a 24 if I can in the patch test. And then obviously as you get rid of the target at maybe treatment 2, then you can repatch test for the next treatment. And so you go on. I think, does that answer the question? You don't want to swell or blister. So absolutely, I've never actually had blistering. Obviously, it's different when you're treating tattoos, but swelling, you've absolutely got to tell them to expect swelling, because even if they don't get it, then that's a bonus. But you've got to tell them to expect to get some swelling.
You're treating around here, it's not uncommon, is it? To get some swelling.
Exactly.
Yeah. Let's see what we've got. Oh, Hayley's come up with a good suggestion. Why don't we do a discount on the round block? Order today and you can get 20% off. So there you go. Our sales director has given us 20% off. If anyone wants one of those today, just let me know. If you email clinical or info@lynton.co.uk, then we'll pick up those emails. Oh, Kerry, I think we've lost you again. I think Kerry might come back. What else we got here? I think Kerry, you back with us?
Am I? Have you got me again?
Yes, you're back.
Yeah. Okay.
I think we've still got a few more questions, but our hour is up, so I think we might have to end it there. But if anyone, as I said, if anyone has got any questions, email clinical@lynton.co.uk and we'll get back to you. And if anyone's got any particular questions for Kerry, again, if you send them to us, then we can forward them on to you.
Yeah, or I'm quite happy if you want to follow our Instagram page. It's Laser Skin Solutions UK, and feel free to send me any messages if you want any answers to questions or anything. So yeah, but buy the blog; it's amazing. I wouldn't without it. So.
Brilliant. Okay, well, thank you very much, Kerry, and thanks for joining us, everyone. And keep an eye on our face. Sorry.
It's my pleasure.
Keep an eye on our Facebook page, and all of the future webinars will be up there as well. Okay, take care, everyone. Bye now.
Thanks, guys. Stay safe.